Doctor, it's all yours.
Good evening, everyone. It's been, I can't believe it's been 20 years since I've been doing this. And I'm very honored and thank you for having me come to you guys and speak again. I think the first time I spoke was approximately 2001. Back then, we didn't have anything called PayPal or Zoom. Just good old fashioned stand on a stage and talk. And we had, I think I just wrote everything on clear paper or those clear things, and you put it over a light and the light just projects what I write onto a screen. So, and let alone, there's really not much talk about genetic testing back then. So certainly things have changed in our world, prostate cancer world. And today and you guys are definitely at the forefront of learning what's new based on all the amazing speakers you guys have had come over in the last, many years. So today's topic is something that's been gaining some momentum in not just prostate cancer, but in general oncology overall. And the topic, of course, is the role of genetics. And specifically in prostate cancer, we're going to talk about genetic testing in prostate cancer. Let me see if I could. Here we go. So we'll go over. I'll try to touch upon there's 5 different indications or uses of genetic testing in prostate cancer. One is to screen if person or patient has what we call clinically significant prostate cancer, and as a result maybe help us decide is even a biopsy needed. Another indication would be once someone is diagnosed, genetic testing can help us stratify his risk and also then help him make a decision about active surveillance. A third indication would be once before or after treatment, we can predict his likelihood of relapse, likelihood of bone metastases, and that will also help us tailor his treatment as well, leading to number 4, guiding treatment. And the last topic is, the last indication is a little separate from the first 4, but this is what we call hereditary genetics, which is genetics that are related to, that's passed down from one generation to another. Prior to going into the whole concept of genetic testing, let's talk about, what exactly is a gene. A gene is made up of DNA. And so a DNA is made up of molecules called nucleotides. And there's 4 nucleotides. If you see at the bottom, it's adenine, cytosine, guanine, and thymine. And just based on various combinations of these nucleotides banded together, you can get billions of different types of genes. A gene is then, we all have genes that we inherit. A gene is then, it's kind of like the father of our body or mother. And the gene subsequently is involved in making amino acids, which then are put together and become proteins, and proteins that are then put together to become a cell. And the cells become sheets of cells or tissue, and lots of tissue becomes an organ. And we are made of a bunch of organs. We are called an organism. So the one way to separate genetic mutations is the type of genes that we carry on and we pass from us to our offspring, and that's what we call germline transmission of genes. And there are some mutations that we carry that we pass to our offspring. And these types of mutations are called germline mutations. And our offspring who carry the gene then are more susceptible to certain cancers depending on the gene. We'll talk about that as well. A separate type of mutation is the genes in the cancer cell itself. So think of the germline mutation as mutations in the carrier, the host. And somatic mutation is the mutations in the unwanted guest, the cancer. And these unwanted guests, they come from normal cells in our bodies, but after certain mutations, they become cancerous. So these mutations are called somatic mutations. These mutations within the guest do not get passed on from generation to generation. They tend to manifest itself as cancer later on in life, as opposed to the germline mutations that are inherited. Little back up. Let me back up a little bit about, just to give you guys some background information, which I'm sure you guys know about. Prostate cancer is a very common disease. We diagnose close to 200,000 cases every year, and 30-something thousand men still die from prostate cancer. It may, it's not like pancreatic cancer where almost everyone who's diagnosed passes away, but 31,000 is still a lot of deaths. In fact, it's the second most common leading cause of death in men after lung cancer. It's diagnosed very often, so approximately 1 in 9 men will be diagnosed with prostate cancer in his lifetime. And in fact, because so many people are not dying, thank God, there's over 3 million men in the US are currently living with it. But still, eventually, approximately 1 out of 40 men will die from prostate cancer overall. Not 1 out of every 40 men with prostate cancer, but 1 out of 40 men in this country. The PSA testing, which is one of our important screening tools and very important to help us decide someone's prognosis, was nationalized, became very popular in the 1980s. And prior to the PSA testing, we really didn't fish for cancer and find it early and treat it early. Prior to the PSA era, we only found the prostate cancer when it was very advanced. So in fact, only 1 out of 5 people were diagnosed with an early stage, whereas 4 out of 5 people were diagnosed with advanced prostate cancer. Since the PSA era, it's basically flipped around. Most patients are diagnosed with localized disease, and only about 1 out of 5 men are diagnosed with advanced cases. However, there's been somewhat of a controversy in the early 2010s. One of the the government groups actually thought that prostate cancer should not be screened with PSA. In fact, they were thinking we should not, they were suggesting to insurance and Medicare not to even pay for PSA testing. Their argument was the benefit of diagnosing these people early didn't actually necessarily outweigh the risk of telling people they have prostate cancer early. And it actually took about 1,000 patients. You have to test about 1,000 people to actually save one life. So, plus, once one is diagnosed, there's a lot of costs involved. There's a lot of complications just from even a biopsy, and there's complications with treatment, which may help a patient live longer, may not, but definitely causes side effects to a certain extent at least. So there was and still is somewhat of a controversy about the role of PSA testing. So, and this goes back to the fact that prostate cancer is not like pancreatic cancer, for example. Many prostate cancers are slow growing. Most prostate cancers are not lethal. So for these men who are diagnosed with slow growing, non-lethal prostate cancers, they're actually being overtreated and harmed actually. So the other argument about overdiagnosing and screening early is some people argue that, well, if you diagnose a little later, even if it's advanced, the treatment is still so good now, you could still help people live a lot longer. So there's less advantage of diagnosing early, contrary to what clinicians and patients are kind of brainwashed to think, oh, everything you have to diagnose early, or else, you know, it's terrible. But diagnosing early sounds great, but it also means, you know, more suffering, more anxiety, and more side effects, of course. So in the perfect world, we would be able to diagnose people, but really do a good job about finding out who needs treatment and who doesn't. And we call the patients who need treatment are the ones who have what we call clinically significant prostate cancers, as opposed to the ones that really are insignificant and won't really affect a patient's life except for add a lot of anxiety and doctor's visits. So there is a role of genetic testing to answer that question. In fact, the genetic testing can even help us before a patient undergoes a biopsy to tell us if we think he has clinically significant prostate cancer. So we could do genetic testing right at the beginning before a patient gets, you know, swept up into this prostate cancer tornado of biopsy, picking a treatment, side effects. Perhaps we could even save that patient from going through all that heartache, mental and physical, with some genetic testing. So let's go over that role first. So oftentimes, you know, the first step a patient gets, how he gets initiated into this prostate cancer world, is his primary care doctor checks that PSA, and which, as we talked about, has some controversy. So the PSA is checked, and the next step is, oh, we got to do all this extra stuff. Some people have what we call an elevated PSA density, so a normal PSA, but the prostate's very small. So even for a small prostate, that PSA might be a little bit high. Or there's a very, you know, or if his primary care doctor is very motivated, he examines the patient and feels something not right. It doesn't have to be a blatant nodule, but just something feels not right. Patients get sent to the urologist. Or, you know, a little bit further down the line, they do ultrasounds or MRIs and they see something. And further down the line, other factors, the size of what we see will help us decide who needs a biopsy. And another test is a kind of a more sophisticated PSA. It's called a 4K score. It's not genetic, it's just a special, I call it a special super PSA. So these are the people who get initiated into this biopsy world. And there's a lot of patients who, you know, if they have obvious situations where they need a biopsy, I don't think we need to do a genetic test. It's really where the patient is not, his situation is not obvious, and there's a concern that, you know, there's a good chance that there's nothing serious. Rather than throw them into the needles and biopsy right away, perhaps there's some testing that will help us avert the biopsy. So borderline PSA. You don't see anything on an ultrasound. The exam's just subtle. So for those people, there's definitely a role of genetic testing. So this is an example of a guy who presents, a 55-year-old man, no family history. His PSA was high, a little bit high at 6. His PSA density is 0.17. The exam by the doctor showed nothing. His gland size was normal, hence the PSA density was 0.17. And we did an ultrasound, and we showed a very small 6 millimeter, which is less than 1/4 of an inch little spot. So nothing blatant. So this is one of 3 genetic tests that I'm just going to go over real quickly that we do to help us decide if the patient needs to take the next step and do the biopsy. So the first test is called Exodx. This is a urine-based test, and it's basically very simple. Patients urinate into a cup, send it to this lab, and they run the test. And the goal of this test is it's to predict whether or not this patient has a high likelihood of what we call the clinically significant prostate cancer. It's going to be based on the results show up as what we call the IntelliScore, or they call it IntelliScore. So again, this is a little simpler, easy way to remember. It's for men 50 and older. They're thinking about whether or not they need a biopsy. Their PSA's abnormal, not too high, just between 2 and 10. The urine is collected one doesn't have to do a prostate exam. The patient just urinates. And the urine is looked at for 4 genes, the ERG, PCA3, SPDEF, and the RTQ-PCR gene. And depending on the quantity of the gene and the ratio of the genes, they come up with this IntelliScore or EPI score. And basically, it's very simple. If the score is high, that means and high meaning above 15.6, the patient has a higher risk of clinically significant prostate cancer. And if the score is low, less than 15.6, they have a lower likelihood of clinically significant prostate cancer. It's not telling you that you don't have prostate cancer. It's telling you whether or not you have the type that needs treatment. So another way of looking at it is if I could feel confident in telling a patient, you don't have clinically significant prostate cancer, when I biopsy you, I'm confident all I'm going to see is either no cancer or clinically insignificant prostate cancer. That's the type we don't treat anyway. So if we're not going to treat anyway, why subject you to the biopsy? So obviously we got to be pretty comfortable and confident about that. And this is one of the tests that could help us feel confident or not. Another test, which is basically doing the same thing, it's called the Select MDX urine test. It's looking at a separate set of 3 genes, and they also use the other clinical factors such as age, PSA, whether or not the prostate is big or not, and whether or not there was a prostate exam. So it's this test is looking at genes and the clinical factors that brought the patient in the situation in the first place. Again, this is to predict whether or not the patient has clinically significant prostate cancer. So same thing, someone who gets screened, has an abnormal PSA or prostate exam, does a urine test, and the urine test will then tell you to do the biopsy or not to do a biopsy. So to summarize quickly, it's pre-biopsy, there's 2 tests, Exodx and Select MDX. Okay, what if a patient actually had a biopsy already and the biopsy was clear? Okay. Does that guarantee that the patient does not have prostate cancer? Unfortunately, no. The only way to guarantee if a patient doesn't have prostate cancer is to remove the whole prostate. Obviously, we're not going to do that. Some doctors even do what we call a saturation biopsy. We biopsy the heck out of it, 100 cores until that's how we feel comfortable. Well, we don't want to do that to a patient either. So the standard typical number of biopsies that urologists routinely do is 12. So it could be 12 to 16. But biopsies are typically not lesion directed. It's just kind of randomly sampled. So it's like throwing out a net and hoping you catch something, or asking a lady, "Oh, you have an abnormal breast cancer marker. I'm just going to randomly poke each breast 12 times and hope I catch cancer." But that's what we do for prostate cancer, unfortunately. So in other words, these biopsies, there are side effects and not comfortable, and there's risks, and they may miss the cancer. So if you look at the picture in the middle of the slide, the red spot being cancer, you can imagine if your prostate's, especially a big prostate, and you just randomly sample 12 pieces, which typically is only less than 1% of the prostate, there's a decent chance you're going to miss the cancer. So that's when urologists will say, "Oh, let's now do an ultrasound. Now let's do an MRI, or let's do another biopsy in 6 months." So what do we do with this situation? We're still not completely comfortable. There's no clinically significant cancer. The patient just suffered through his biopsy. Now what? Do we have the heart to ask him to do another biopsy just to be sure? Do we say, "Oh, let's just take 100 cores and just to be sure"? Do we just take out the prostate just to be sure? Well, perhaps there's something a little bit more, less gruesome than that approach. So there's another test called Confirm MDX. So Confirm MDX it is actually made by the same company that did Select MDX. What they do is they look at a bunch of genes from the biopsy. So not urine, not blood. It's from the biopsy that was removed that showed no cancer. Because we know that oftentimes, even though there's no cancer on the slides, the adjacent cells that do not have prostate cancer still could have the abnormal genes. So you're testing the normal cells for abnormal genes. And if the Confirm MDX shows that there are a lot of abnormal gene expression, then yes, definitely do another biopsy, do some imaging, keep investigating. If, however, this genetic test of the biopsy came back favorable, then you'd feel a lot more confident not subjecting a patient to another biopsy. So that's the role of genetic testing in the pre and the biopsy question indication. Another indication for genetic testing is, what can genetic testing help us? How can it help us after a patient's been diagnosed? So these are patients who have cancer on a biopsy. So number one, it can tell us, remember we said there's a lot of men with slow growing cancers, or a lot of men who don't ever need treatment. There's a lot of men we do active surveillance. These are the men we overtreat. So genetic testing is another way to give us more conviction to recommend treatment or recommend no treatment, and just recommend active surveillance. So there's 3 different genetic tests that I like to just review with you guys that will tell us or answer that question. So a lot of these patients typically are Gleason 6 or very low volume, low grade Gleason 7, who are still considering active surveillance. Again, if you have Gleason 7, 8, or high 7, Gleason 8, Gleason 9, Gleason 10, this genetic testing is not going to convince us you don't need treatment. The Gleason score is already enough to tell us you need treatment. So this is a the standard typical patient who does not need treatment. His PSA is less than 10. There's no nodules. Or just a very small nodule. The Gleason score is usually 3+3 and a few low volume 3+4. Not very many number of cores showed cancer. You see no spots or only a tiny spot on imaging. And of course, they have a favorable genetic profile, which we're going to talk about next. So the first genetic test is called Polaris. And this test, again, looks at and this is looking at the abnormal cancer cells from the biopsy. So this is not looking at the host, this is looking at the cancer. So Polaris will look at these cells and look at 31 different cancer-related genes. And depending on the ratio and degree of expression of these genes, they come up with a estimation of the risk, whether or not this is a type of dangerous prostate cancer or not. Let's see here. This is a little. I'm gonna jump into the next slide here. These are the genes that they look at, and then remember, these are all patients with, on the surface, patients who we think we're just going to watch, okay? And or we're considering active surveillance. This test will tell us further if this patient is, it supports our hypothesis that we don't need treatment, or does this test say, oh, well, on the surface he looks pretty good, but based on the genetic testing, his cancer has bad genes, you might want to consider treating. So let's see here. Do you guys see the arrow here on the screen? There's a little white arrow.
Yes.
Okay. So basically, the most important thing we look at this when we look at the report are these two items. So the genetic profile will tell us if the patient's genetics are more aggressive or less aggressive than the typical low-risk patient. The second piece of data this genetic test tells us is what is the risk of this patient dying of prostate cancer in 10 years if we simply watch them until absolutely necessary. So with this information, we could then advise patients, well, you're 55, your cancer, it does look a little bit more aggressive than what we thought based on the genetics. And 6% in 10 years is actually not negligible for a fairly young person. So maybe we might want to err on treating rather than active surveillance. On a similar vein, this is a different genetic test. And this is, it doesn't, the primary question this one asks is once we remove the prostate in you, for example, what's the likelihood that your cancer is going to be more aggressive than what the biopsy showed? And this test is called Oncotype DX, and it's looking at basically this gene called the loss of P10 gene. Again, it's done on the biopsy, and the results come out as a score, 0 to 100. And again, these are used for patients who on the surface have low or intermediate risk, and we're doing this test to reassure us or tell us we better not do active surveillance. Again, these are a lot of the genes that portend aggressiveness or less aggressive. And so this test, so for example, this test, if we had, the goal of this test is really this group of people, okay? Meaning this group of people, they have intermediate risk, they should get treatment. This group of people we really think have low risk, they don't need treatment. It's really this fairly low risk patients. After you do the test, you may end up either moving some of these guys to the very low risk category, or moving some guys into the higher risk category. So we call this risk stratification. So you could change the recommendations for this group of men and this group of men. A lot of men, their recommendations don't change, but this test can help further refine our recommendations. Again, it comes out, their results show a score, and then they put it in this very low, or intermediate category. And they also can tell you what's the likelihood that if we did surgery on this guy, what's the likelihood that the Gleason score is indeed low. It's 84%. This is a third test. It's called Decipher. And again, this is looking at, it's also kind of like Oncotype. It's predicting whether or not the patient has higher Gleason scores. This test, again, looking at genes, also is able to predict the risk of metastasis in 5 years, risk of dying of prostate cancer in 10 years. And it's not only used for patients that are just deciding active surveillance, but it's also going to help us decide if a patient might need hormone therapy, or if a patient needs will need surgery then radiation, or multiple types of radiation. So give us more information with this genetic test. And I figure looking at the report is going to be a much easier way to kind of explain things for everyone. So this is a patient with a PSA of 10. He's intermediate risk, but the biopsy was 3+3. But there were, what made him intermediate risk was the PSA of 10 and the borderline number of cores involved. So he's intermediate risk, but looking at the genetics of the biopsy, the cancer cells, Decipher is able to tell us, well, he's actually lower risk than what we thought, even though the PSA was 10. So the risk of having high-grade disease on surgery is only about 13%. Risk of metastasis is only 1% in 5 years, and risk of death is only 2%. So this person, even if he's a little younger, maybe 2% is not that bad. We don't want to give him incontinence and impotence, jump into that. So perhaps this is a person we would do active surveillance. The next indication for genetic testing is, well, after a patient has had treatment, based on genetic testing, can we tell him what's his prognosis? What's the likelihood the cancer will come back? So there's Decipher has a separate test. Metastasis goes down. Some men, if you could, delay radiation until after the PSA comes back. But Decipher is able to tell us, well, the PSA is not up yet, but we better do some radiation because based on this genetic profile of this patient, he is going to have a higher likelihood of relapse and a lower likelihood of remission if we do radiation too late. So this is helping us decide if radiation needs to be done right away versus when the PSA comes up. They're trying to ask other questions with genetic profiling. And this is not what we call standard yet. There's not enough studies to support it. They're still doing research. Eventually, the genetic testing will even help us tell us what's the likelihood of radiation working or not, what's the likelihood of chemotherapy working or not, what's the likelihood of hormone therapy working or not, and how long hormone therapy will work. And so this is kind of in the future after someone has had prostatectomy. In a lot of men, who have had treatment, we still used, and who relapsed, for example, we still use genetic testing to help us manage their disease or help us choose treatments. And this is the fourth indication of genetic testing. So for men who are metastatic, who have metastatic disease, that means they need hormone therapy or androgen deprivation therapy. But eventually, metastatic disease, androgen deprivation or hormone therapy stops working. So we call that castrate-resistant metastatic disease. And typically, for these men, we then go through a whole slew of different treatments to help prolong their lives. And with the help of these genetic tests, we can maybe fine-tune the treatment recommendations or potentially uncover new treatments when these treatments stop working. So I'm going to go over some of these tests. One's called Foundation 1, one is Guardant 360, one is Caris. They're basically all doing the same thing, which is they're looking at the cancer itself and finding out characteristics about it, either using blood, the cancer cells floating in the blood, or actually the cancer cells within a tumor, for example, and studying those cancer cells and seeing what might work, what might not work. So Guardant 360 is one of the first ones. Their test is a blood test, and they basically just look at the DNA that's released from the cancer cells, and they look at a bunch of genes and hopefully try to uncover something about the genes that will portend and predict for some treatment options. So these are the genes they look at. There's 68 of them. The ones that most people are familiar with are the BRCA genes, but we're trying to learn more about other genes such as KRAS, which is in colon cancer, MET which is in a bunch of sarcomas. Let's see, EGRF, which is lung cancer. So we're looking at if these other genes eventually will mean that we could start using those anti-cancer drugs for prostate cancer. And these are some other genes that are being studied right now. Foundation 1 is a competitor company. They primarily use tissue rather than cells, the cancer cells. I think they just started looking at blood, extracting cancer cells from the blood, but in the past they used tissue only, so you need a biopsy for this. They look at more genes, again with the goal of finding treatments or maybe helping patients enroll in clinical trials. And these are their genes that they're looking at. This is a sample of their report. Oops. They'll say, this is a patient with colon cancer. They found these 3 gene mutations. They found a 4th one. And then they say, based on these gene mutations, you can try this. This is FDA approved. Or there's no drug for this gene mutation. Well, you do these drugs first, but there's no other drugs after that. So maybe you could have a patient go to clinical trial. Or if you have this gene, there's no trials, there's no FDA approved drugs, but consider going in a clinical trial if you have this gene mutation. So there's a lot of the take-home message is there are a lot of trials now. We call them tissue agnostic or cancer agnostic, meaning you don't have to have a specific cancer to get into this trial. Your cancer just needs to have this specific gene mutation. So you could participate in a trial with a group of men and women with various cancers. Doesn't have to be prostate cancer, testing a drug, because the commonality is the gene mutation, not the cancer itself. So this was what I was trying to tell you guys about trials. Okay. Oh yeah, that's right. So Foundation, I did have a slide for that. So they have this is the one that they just started using, which is using peripheral blood. They don't identify the couple hundred genes, but they look at 62 genes with using just a blood draw. So why is genetic testing helpful for treatment? Well, this is one of the first genetic mutations that we found that actually helped us with new treatments for prostate cancer. So about 5 years ago, the researchers found that prostate cancers that have the abnormal BCR gene, there's actually 4 of them. It's CHEK, ATM, Fanconi, and the BCR gene. If you had those mutations in the cancer, not the, this is separate than someone who's inherited it. If you gave that patient olaparib, you'd have an excellent response rate, as opposed to if you did not have the gene mutation. So it could be as high as 80% response. So and this drug was never meant for prostate cancer. This drug is actually meant for ovarian and breast cancer. But who knew that if you have prostate cancer and your cancer has this mutation, this breast cancer drug, this ovarian cancer drug will work for you in over 80% of the case. So these are the genes that what I was referring to, that if your cancer cells have this mutation, these 4 mutations, you can have a pretty good response with olaparib and rucaparib, ovarian cancer drugs. We've also learned that patients with these type of mutations have a better response to certain chemotherapies that are platinum-based, such as carboplatin. Another type of genetic mutation is what we call microsatellite instability. We've learned that about 3%, not a lot, but 3% of men with metastatic prostate cancer have microsatellite instability in their genes. And those men respond to immunotherapy with pembrolizumab. So in terms of guiding treatment, unfortunately, this is it. So we're only in the first inning of using genetic therapy, genetic testing to find new treatments for men with prostate cancer. But I do think the ramp up in the next 5 years will be very fast as we learn more and more about genetically what these cancers are doing. And in fact, this is very important in all cancers, not just prostate cancer. Another way genetic testing is helping us deciding treatment is a gene that is called the ARV7 gene. This gene is called ARV7, means androgen receptor V7 gene. Turns out that if a person's cancer has a mutation, or they call it the splice variant, drugs such as Zytiga, abiraterone, or Xtandi, enzalutamide don't work very well. So, for example, if a patient was treated with Zytiga and the cancer started progressing, and we do an ARV7 test, and if that patient has ARV7 mutation, then the likelihood of enzalutamide Xtandi working is only about 5%. So we would say, well, let's not waste your time to do this Xtandi. We should jump to something different. On the other hand, if you don't have this splice variant, then there's a decent chance, about 50% chance, that Xtandi would still work. So this is kind of like you're at a crossroads to decide what to do next if Zytiga stopped working. That's how I use it. Again, this is a blood test, so it's very easy to do. And what the researchers are doing is they're trying to find drugs that specifically target cancer cells with this mutation, and hormone therapy drugs. Finally, so the first 4 indications of genetic testing all pertain to the genetics of the cancer, or what I call somatic mutations. The last indication for genetic testing is what we call hereditary genetics, meaning cancer syndromes that are passed down from one generation to another. So these are men and women who basically their genetic makeup makes them more prone to cancer. So we call this hereditary genetics. So it's inherited. We're not really looking for cancer. So there's really nothing to biopsy. You just check, just like detectives take a strand of hair to look at DNA. Germline mutations is you can check just from blood or saliva. And if you have these mutations, it will tell us what type of prognosis you have. It can guide treatment. It could remind us to screen for other cancers in you if you have this genetic mutation, and also help us, predict or counsel your family and your offspring to make sure that they're screened earlier in case they are more prone to cancer at a younger age. So the genetic mutations are inheritable that we know the most about are the BRCA1 and BRCA2 genes. And the most famous person with this gene is Angelina Jolie. So she inherited this gene mutation from her mother who died of ovarian cancer. So she had this gene, which made her prone to breast cancer, ovarian cancer. But if she had brothers, they would be prone to prostate cancer, and they'd be prone to pancreatic cancer. And actually, men with this gene are prone to breast cancer. So if you have this mutation, there's actually the same drugs that we use for ovarian cancer and breast cancer work for you if you have prostate cancer. Let me think here. Yeah, I think so. So the take-home message for BRCA is typically it's the prognosis is a little worse. If you have the gene, there's a 50% chance that you could pass it on to your offspring. It's associated with other cancers, such as breast, ovarian, pancreatic, skin cancers, and prostate cancer. And another point is these cancers tend to occur at an earlier age, and they respond to Parp inhibitors. So an example would be, I have a patient who's 40 and he has prostate cancer and it's aggressive. I would test his whole family. If he had 10 siblings, there's actually a 50-50 chance that each sibling will have it. So about 5 of those 10 siblings will have this gene. And if they have this gene, they're prone to getting these cancers at a much earlier age. So you're really not just helping the patient with this gene, you're helping all his siblings and offspring. Another, the likelihood of this gene being found is only about 3%. However, if the more suspicious family history you have, the more, or if a patient has metastatic disease, there's actually, just on routine screening, there's about a 15% chance that you have that gene. And if you have it, then you're open to more treatments, and there are a lot of implications for your family, as I stated. Another set of genes that we're learning more about is these are all related, the ML, HL, MSH, MSH6, PMS2, EpCAM. These are all related genes. Again, they're 50-50, 50% chance of passing on to your offspring. They're not, just because you have this gene, it doesn't necessarily mean you have a worse prognosis, but you are more likely to have other cancers such as colon, stomach, liver, skin, kidney, brain cancer. This is a little less common than BRCA, but this is also a important inheritable genetic mutation. It's very important therapeutic-wise because it's the immunotherapies that really work well against these genetic mutations. So I was referring to earlier, if you have metastatic disease, you can have at least up to 12% of men with metastatic disease will have the BRCA, the BRCA2 ATM check genes. These are the Angelina Jolie type genes. Another 3% will have the other genes I talked about right here. And if you have localized disease, again, it's a much lower likelihood than if you have metastatic disease. So I was referring to, us being in the first inning of using genetics mutations to help us find treatments. And these are all the different types of treatments all the research around the world are working on to fight cancer, targeting specific genetic mutations. So hopefully in the next 5 to 10 years, we're going to have multiple new options for treating advanced cancer. So to summarize, these are the 5 indications for genetic testing, which of course, 1 is to decide if a biopsy is needed. 2 is to help us decide what to do after one is diagnosed. 3 is to give us a prognosis after treatment and perhaps tell us if we need to do radiation sooner rather than later. Number 4 is kind of guiding treatment in metastatic cases. And number 5 is in men who have inheritable genetic mutations. There's a lot of implications, clinical implications for that as well. So with that, I'll conclude the lecture portion, and we have some time for questions. Thank you.
Doctor, thank you very much. That was fascinating. And what I didn't expect tonight was that there were going to be so many different tests for so many different purposes. And I thought we were going to discuss a test. This is amazing.
Thank you.
No, thank you. Something a little different tonight in the questions. I'm noticing some internal conversation on chat. That's fine. I keep doing that. But I don't know that everything here is actually a question. So if I accidentally skip over your question, resubmit it. Hey, Neil, you didn't ask my question. And we'll find the first question. Let's see here. This is from Victor. Excellent question. Who is doing these very useful sounding tests on the biopsy material? This is a question specific to biopsy material. Okay. And how prevalent are these tests? Do we as patients need to advocate for these tests? So it's a 2-part question.
So Victor and everyone, yes, you guys definitely need to advocate. I tell patients the person who cares most about you is yourself. So doctors are not uncaring, but there's so many tests. They're busy jumping from one patient to another, and documenting and filling out forms. So yes, this is great. You guys, the goal is to get you guys armed with information so you could go to your doctor. Whether or not, at least bring it up and then see if, number 1, if the doctor knows about it, but maybe you guys could have a dialogue. He could say, yes, you're right, Victor, you do need this test. It would help us guide your treatment. Or no, it's not going to help, but thanks for bringing it up. So yes, definitely advocate for yourself. So for an example where this test may not be helpful, I'll give you a couple of examples. Number 1, let's say you did your biopsy and you have Gleason 6, but there's still something where we want to be sure. The doctor says do active surveillance, but you're still not completely sold on it. That's where the genetic test is helpful. Another scenario is, and the genetic test is based, again, the slides are sent to the company that runs the test. So, and in general, Medicare and insurance companies do pay for it. There's just some logistics involved, phone calls, shipping, and coordination, but it's all doable. Another scenario where after the biopsy, one can think about genetic testing is, let's say you do have Gleason 8, Gleason 9, and the doctors, and we say, well, you're going to need treatment no matter what. This testing is not going to tell you if you need treatment or not. But one could say, well, what about germline testing? Did I inherit some gene that predisposed me to this terrible cancer that needs treatment? So if I do have this gene, which is tested with some blood or saliva, then I need to know if I'm going to be prone to, then I need to be screened for pancreatic cancer. I need to be screened for breast cancer. I need to tell my kids. I need to tell my siblings. So it's also important for that sense. So next question.
Okay. Any comment, this is also from Victor, any comment on the color test, COLOR in all capital letters?
So the color genomics that is also looking at germline mutations, inheritable. So it's one of many brands. That's a saliva test. So it's not a test for someone who has, it's not to test a biopsy. It's just to test if that patient inherited some mutation.
Yeah, or blood, yeah, which I did, yeah.
Yeah, color does blood as well, you're right.
Okay. Again, Victor, please discuss what is meant by olaparib working for you in quotation marks. Some reports suggest adding some months, but not a long-lasting effect. So I guess we're asking about the efficacy of this medication and your views on it.
Yes. So
this is Parp inhibitor. How much benefit does Parp inhibitor really give? Is it like 9 months additional overall survival late in life, or because people say, well, this is a great thing. It treats you when you've got BRCA2, and then and it might give you 6-8 months. Right. So I'm curious about your senses of that.
So one thing, when one has metastatic castrate-resistant disease, every drug that's been approved has extended life by 3 months. It's not because these drugs only work for 3 months. These drugs were part of studies designed just to show a difference in survival, just to show if they work or not. So in general, for advanced cases, a drug for someone who's heavily treated, metastatic, poor prognosis, they can either not work, or they work on average 3 to 4 months, or they actually can work 9 to 15 months. But for someone who's very advanced, who's tried multiple drugs, these PARP inhibitors, I've seen them work actually 2.5 years. So I started using them 4 or 5 years ago. I've seen them not work, but it's definitely something that's worth trying, because I definitely have patients that it works for a couple of years, which is great.
Yeah.
Okay. Let's see here.
One more thing.
Oh,
So
please. Go ahead.
Just like Xtandi, Zytiga, chemo, these drugs were shown to work in the very advanced cases and prolong life for a short period. As they've been sitting on the market longer and more investment's been done, they've been studied for earlier stage cancers, and they do make difference for years. And I suspect for PARP inhibitors, just like in breast and ovarian cancer, when used much earlier in the journey of these cancers, they do work much longer.
Yeah, that's certainly one of the key questions, is at what point should they be applied, if you are BRCA2 positive, for instance.
So unfortunately, right now, the standard is wait till so many things stop working and then use PARP inhibitor. But they're working on more, they're gathering data, they're researching how much extra benefit it would work earlier.
Okay. Question from Phil. What about PD-L1 biomarker expression? Didn't see it anywhere on your slides.
So PDL1 is basically it's a mutation to it's not necessarily actually a genetic test. It's looking at a expression of PDL1 on the cancer surface. And to summarize, people who have this abnormality will respond to immunotherapy. It's a test that you use on tissue, and it's only about 3 to 4% likelihood that one has that expression. I referred to PDL1 in a different manner. It's the microsatellite instability, but they're kind of interchangeable. So if you have microsatellite instability, you'll have a better response to immunotherapy. If you have PDL1 expression, you will have a response to, you have a good chance of responding to immunotherapy. But that only happens at this point at most 5% of patients.
Okay. Question. I'm sorry, did you want to? Question from Adrian. If one has had a favorable Decipher or similar genomic test, should you also have a genetic test using blood, saliva, or urine?
If you have a favorable, and again, that's somatic mutation, you almost have to look at two separate things. If a patient typically has favorable risk prostate cancer and substantiated with somatic testing, Prolaris, Decipher, et cetera, I don't routinely just go screen for genetic mutations that are inherited. Unless that patient was diagnosed very young, has siblings with cancer, has more aggressive cancer, you don't routinely go testing everyone for inheritable genetics.
Okay. From Marty, two-part question. For metastatic disease, when and where would you get a tissue sample for genetic testing? And the second part is, will testing the BX possibly spread the cancer? Is a wet BX good yet?
Well, typically prostate cancer goes to the bones. So a biopsy of a bone is difficult and the yield is low. So we typically do not go there. We try to get lymph nodes, and if there's no lymph nodes, then we forego the tissue biopsy. That's why there's such a value in blood testing for cell-free DNA for somatic mutations. Does a biopsy spread cancer? Oh, that's a big question. I would say no.
Okay. Chuck asks, what are the sensible tests for metastatic prostate cancer and a Gleason score of 7 or 8?
What is the what?
I'll ask the question again. What are the sensible tests for metastatic prostate cancer if you have a Gleason score of 7 or 8?
So are we talking about genetic testing, I presume? So if you have a Gleason 7 or 8, the higher the Gleason, the more of a role of germline testing. If you have a Gleason 7 or 8, and sometimes I use Decipher of the biopsy to help me decide how long to do hormone therapy, whether or not the patient needs 2 types of radiation for his treatment. So that's where I would consider genetic testing.
Okay. Alan has a question. Also, which tests make more sense for a Gleason score of 6 or 7?
So any of the 3 that I talked about, For the biopsy, patients who are, Gleason 6 or 7, if you're thinking about active surveillance. So Prolaris, Decipher, Oncotype, they're all kind of competitors. I can't say which one is better. They've never been compared head to head. I've been finding. Pardon? So I would recommend. I've been having a better feeling, I get a better data. It seems to me. It helps me a little bit more with ExoDX and Decipher.
Okay.
Wait, I take it back. Not Exo. It's Decipher and Oncotype. Exo is the pre-biopsy one. Sorry.
A question from Larry. Will the genetic test Decipher indicate a reliable effectiveness in determining the use of HT?
We don't know yet. That's still being studied.
Larry, unmute yourself. Larry, hold down your space bar. Hold down your space bar. Larry, hold down your space bar. You're muted.
Still muted, Larry.
Uh,
Unmute yourself in the lower
There
left.
you go. Thank you, Dave. Can you hear me now?
I can hear you.
Yes,
Okay.
we can.
I want to thank Dr. Lamb for his appearance here. I very seldom use the word excellent, but you gave an excellent presentation about genetic testing. Okay, our group, our directors and our advisors have been exploring ways that we could introduce this new testing mechanism to our group, and you have addressed that very nicely. Thank you, Dr. Lamb.
Oh, thank you for having me.
Thank you. We got for those not familiar with the term HT, Larry, you're still with us. What is HT? For those not familiar with that.
Hormone therapy.
Hormone therapy. Thank you.
Yeah.
I have a question here.
It turns out the best predictor of hormone therapy is the Gleason score and the amount of cancer when hormone therapy is implemented. We do not know if genetic testing will tell us more on top of that information. We all know that hormone therapy can work 2 years, it could work 20 years. And we have a pretty good idea of how long hormone therapy is going to work based on the Gleason score and the amount of cancer. Perhaps with more data, genetic testing will refine what we know and tell us to more certainty how long we think hormone therapy will work.
Thank you, Doctor.
I have a question here from someone who was 7 years past surgery when their PSA reached 0.2. Would genetic analysis help in treatment options? If so, which ones? So someone's been through 7 years after surgery and their PSA is climbing up to 0.2.
Right.
What should they look for in a genetic diagnostic?
So we always ask ourselves, is a test going to make a difference, or is it going to give us more information than what we have? For this specific case, you guys know about PSA velocity. If the cancer took 7 years to come back after surgery, it's strongly telling us that the genetics are favorable. So it's unlikely that genetic testing will, maybe 1 out of 20 cases that genetic testing will kind of change our views a little bit or change our recommendations. But this is a case where, well, it's interesting, but I don't think I'm going to suddenly treat the patient with hormone therapy just because the genetic test came back like that. Now, the genetic testing will be helpful the day after surgery to tell us if this patient is a 7-year relapser or a 1-month relapser.
Okay. Ira asks, how does the PCA3 compare with the EXO diagnostic with ExoDX?
So PCA3 was a very old first urine-based genetic test that came out 10 years ago, and so many false positives, so many false negatives. And that gene is part of, it's part of ExoDX. It's one of the genes that's looked at in ExoDX. So Exo looks at 4 or 5 genes, Select MDX looks at 4 or 5. So those are more refined, more accurate.
Okay, I'll open up the floor here to anyone who wants to unmute themselves and ask a question. And the reason why I'm doing that is I may have skipped over your question without realizing it, thinking it was part of a conversation with another participant tonight. Would
Neil,
anybody like to start?
Neil, I'd like to make a remark.
Please, doctor.
Is Dr. Lamb, this is Chuck Metzger. I'm a retired urologist that works with the Fullerton Group.
Hi,
Thank you
Dr.
very much
Metzger.
for a very comprehensive. Hi, we met a long time ago, but you meet so many people, I'm sure you would remember. Isn't it interesting that we're in an era that we have a president that's old enough to surely have prostate cancer, and we have a situation where they're telling us not to do digital rectal exams. So we have all this KY gel laying around and gloves that we're not using. And then we have PSAs not being done. So we're getting more metastatic prostate cancer. And then we have all these androgen receptor thingies going on, and it's getting very confusing. And I don't blame the insurance companies for not keeping up. There's so much out there, yet there's so much hope. It's so much better and so much different than what we were doing. If you look at Don Skinner's USC 1200, 80% of those were Gleason 6s.
Yeah,
They didn't need anything.
that's why his data,
No wonder
his
they were
data's so good.
They were continent. No wonder. The ones that need it, it just is, it's a funny business we're in. But we certainly appreciate your fresh look at things and encourage you to keep doing this. And
Thank you for your
so
kind
much.
words.
Well, they're not kind enough. You're doing a great job, and we really appreciate it.
Thank you. Thank you very much.
You're welcome.
Let me, it's Adrian. I asked a question about if you have a Decipher test, and it hasn't not yet come back negative, comes back positive, then you gotta go do something. You know what I mean? High risk. But if it comes back low, I was thinking that, well, what does it hurt to go have a urine-based test that will tell you if it's aggressive or not aggressive? But again, you just said if it's not going to tell you anything different. And I've seen those described as a genomic test as opposed to a genetic test. And maybe what's the difference there, so I could understand, maybe we all can understand why just doing Decipher, Oxo, or Oncotype, Polaris, or Oncotype, if you do that and come up with a positive result, at least at that point, it's not worth doing any of the urine or blood cell.
Right. So, I mean, you're right. Officially, the urine-based test is just to tell us to do a biopsy or not. What's the likelihood there's clinically significant disease? I'm actually not sure if there's some overlap between the genes, but will having the urine test add more to Decipher Polaris or Select MDX or Oncotype? We don't know if, heck, for reassurance, let's just do every single test, or it is an easy test to do. Do we want it? Will it help much on top of what we already know? Maybe 1%. Again, every test we do, we got to think, what's the likelihood it's going to change our management?
Well,
or how much weight to put on it.
Yeah. So the worst thing is we do a urine test and it comes back showing aggressive, and then everything else is shown not. Then what are you going to do?
Then what are you going to do? Right.
I mean, was it worth the $200 to do that? Now, if that comes back negative again, I'll pester him for the next one too. But I will try, and I understand it better now that you're adding on to where you are, and maybe 2 years from now or something, then you can do that because you'll have,
Yeah.
you're further down the road. Okay.
Right.
All right, that's fine. Thank you. I appreciate that.
So Dr. Lamb,
Yes.
this is Phil DiPaolo. How are you?
Good.
So I'm just checking for those of us who are in this hormone.
I just hear your
sensitive-
voice. I don't see your face. I can't.
You don't see
find
my
you.
face. I'm right here.
Oh, I see it. What a nice background. I see you now.
Yeah. What about men who are sort of trapped in this metastatic hormone sensitive area where some of the advanced drugs or the immunotherapies could be helpful, but they can't get them because they haven't failed androgen deprivation yet? It seems like a real squeeze on people in that situation who might really benefit from certain treatments.
That's true. I mean, it's hormone therapy has so many side effects on quality of life. It could work for many years. Then the question is, well, should one do immunotherapy in lieu of hormone therapy? And is there a role for that? Immunotherapy sounds wonderful, using your own immune system to kill cancer. Unfortunately, it's sometimes it causes a lot of harm. Gosh, I've had patients get uncontrollable diarrhea where their colon just sloughs off. The immune system's so active. Caused diabetes in someone who was perfectly healthy prior. Obliterated his thyroid. Scarred up his lung. It attacked the lung so much that they can't breathe. They're on oxygen. So it's always a balance,
Sure. Thank you.
Our goal is to do no harm.
Right.
Whoa.
Anyone else? We have about 3 minutes. If one last question.
Neil, this is Dave.
Hi, Dave.
People have asked, I think a couple of times, will this be recorded? There was an interruption, but it seemed to be a Zoom glitch. It came back. We'll record everything that I was given and put on the YouTube site. So Neil, don't you announce where that is on the YouTube?
Sure. Go to our website. There's an icon at the very top for YouTube videos, and click on that icon. It'll take you right to it. Go right to our first page at prostateforum.org. And it's a couple of days for that, right, Dave?
Yes, I'll try and get it released. There's some processing and uploading, so I'll try and have it tomorrow.
Super. Anyone else?
Yeah, Doc, in one of the answers that Dr. Lamb gave, he just quickly said something about 2 types of radiation. Would he explain what those 2 types are?
Yeah, sure. So for someone with, so typically radiation can be delivered externally. So using the machine, directing radiation into the prostate, and that's called beam radiation. Other names, IMRT, SBRT, hypofractionated radiation. Another way to deliver radiation is implanting, bringing the radiation, putting it into the prostate via seeds. We call that brachytherapy, or via wires, where there's a little radiation at the tip of the wire, and you put the wire into the prostate. HDR brachytherapy. So beam from the outside, seeds or wires, bring it to the prostate. There are certain cancers within the prostate that are so aggressive, one or the other is not enough, and you need both. And so sometimes the genetic testing further supports that this cancer is super aggressive would give me more reason to do that type of radiation, combining it.
Outstanding. Doctor, thank you very much for your time. It's always a pleasure to see you here at Prostate Forum, and we look forward to seeing you again. Next month will be Dr. Robert Princenthal from California Protons discussing proton therapy. We hope you join us then. If you'd like to be on our email list for the constant contact email blast. Hi, Dr. Metzger. Please email us at prostateforumoc@gmail.com. With that, I'd like to close the meeting. Have yourself a great evening.
Thank you. Be safe. Thank you,
All
doctor.
right. Good night. Thank you, doctor.
Thank you, doctor.